Across the world's rural landscapes, from the farmlands of the American Midwest to the remote villages of Southeast Asia, a disturbing pattern is taking hold. Obesity-related cancer mortality is rising faster in rural populations than in urban ones. This is not merely a reflection of diet or lifestyle. It is a deeper, systemic failure that is leaving isolated communities increasingly vulnerable to preventable death. In these regions, where resources are limited and health infrastructure often stretched to its breaking point, the double burden of obesity and cancer is evolving into a silent epidemic. Obesity is a well-established risk factor for numerous cancers, including colorectal, liver, pancreatic, breast, postmenopausal, and endometrial cancers. But while this connection has gained growing attention in academic and urban policy circles, the unique risks faced by rural populations remain dangerously underaddressed. In these communities, the rise in obesity is often faster and more entrenched, yet the tools for prevention, early detection, and treatment are weaker than ever. The reasons behind this disparity are complex and deeply structural. First, there is the issue of access. Rural residents typically have fewer healthcare providers, fewer specialized cancer centers, and longer travel distances for routine screenings such as colonoscopies, mammograms, or pap smears. Preventive care is sporadic at best and non-existent at worst. As a result, cancers linked to obesity are often diagnosed late, when they are more aggressive, less treatable, and more likely to be fatal. Income inequality compounds the problem. Rural areas often experience higher rates of poverty, unemployment, and food insecurity. Ironically, this economic hardship often leads to overnutrition, not from abundance, but from the lack of affordable, healthy food options. Many rural communities are food deserts, where fresh produce is scarce and the cheapest. Most accessible calories come from ultra-processed, sugar-laden, high-fat products. These diets fuel obesity from childhood into old age, laying the groundwork for metabolic dysfunction and, ultimately, cancer. Physical inactivity is another overlooked factor. While the image of rural life might evoke manual labor or outdoor activity, the reality has changed. Mechanized farming, long commuting distances, and the closure of public recreation spaces have led to sedentary lifestyles, particularly among older adults. Add to this the cultural normalization of obesity in some rural areas, where higher body weight may not carry the same health stigma, and you have a perfect storm of rising risk and reduced intervention. Even when rural patients are diagnosed with cancer, the challenges do not end there. Treatment options are limited. Many small hospitals lack oncology departments. Radiation equipment is rare, and specialists often rotate in from urban centers, if they come at all. Obese patients, who may require more complex or tailored treatments, are particularly disadvantaged. Long-distance travel for care, high out-of-pocket costs, and time away from work or caregiving responsibilities can all discourage treatment adherence, leading to worse outcomes. Telemedicine has been promoted as a potential solution, but its reach is still inconsistent. Many rural areas lack reliable internet access, and older populations may not have the technological literacy or comfort to use remote platforms for oncology consultations. Moreover, obesity-related cancers often require physical exams, imaging, biopsies, and in-person interventions that no video call can provide. There is also a profound gap in data and research. Rural populations are consistently underrepresented in large health studies, and obesity-related cancer outcomes in these communities are not always disaggregated in national statistics. This absence of visibility contributes to the lack of targeted policy response and funding. Public health campaigns often focus on urban populations, where media visibility and political pressure are greater, leaving rural communities in the dark, both literally and figuratively. The consequences of this neglect are already visible. In the United States, for example, cancer mortality rates in rural areas now exceed those in urban areas, and the gap is widening. Obesity is a major factor behind this trend, but one that is rarely called out explicitly. In countries with emerging rural middle classes, such as India, Brazil, and South Africa, obesity-related cancers are rising even faster, but health infrastructure has not evolved to meet the challenge. This crisis cannot be solved by individual behavior change alone. The structural barriers, geographic, economic, systemic, are too high for rural residents to overcome without meaningful intervention. Governments and health organizations must treat rural cancer care and obesity prevention as a national priority. That means investing in rural cancer screening programs, expanding mobile clinics, subsidizing access to healthy food, and integrating obesity management into primary care settings in remote areas. It also means addressing rural poverty and isolation as core health issues, not side concerns. Culturally competent care is also essential. Health education in rural communities must be tailored to local values and delivered by trusted voices, community health workers, local leaders, and faith-based organizations, rather than relying solely on top-down messaging from urban institutions. Weight stigma must be addressed carefully. The goal is not to shame, but to inform and empower people to make choices that reduce their risk of cancer and improve their quality of life. Obesity-related cancer is no longer an urban problem. It is a rural reality, one that is costing lives quietly and steadily. These deaths are not inevitable. They are the result of delayed diagnoses, missed screenings, poor access to care, and a lack of coordinated, culturally aware public health policy. If we continue to ignore the growing cancer crisis in rural regions, we will deepen the divide between the health of cities and the suffering of isolated communities. Rural cancer patients are not invisible. They are our farmers, our elders, our neighbors, our families. Their lives are no less valuable, and their risk is no less urgent. The time to act is not tomorrow. It is now.